Okay, shall I get started?
Yes, I think it's 11. Yep. Thanks, Kay.
Okay. Good morning, everyone. Welcome to today's Distinguished Speaker Series. My name's Kate Dobbs, and I'll be helping to moderate today's session. We'd like to start by dedicating today's session in honor of Dr. Bob Salata, who passed away on August 26th. Dr. Salata was a renowned clinician, educator, and researcher, and a longstanding leader at UH and CWRU. He served as the chief of the Division of Infectious Diseases and HIV Medicine for nearly 20 years, and most recently served as the chair of the Department of Medicine at Case and the physician-in-chief at UH Cleveland Medical Center. As many of you know, Dr. Salata was committed to advancing health both locally and globally. Since 1997, he led HIV/AIDS research as part of the Uganda Case research collaboration. During the Ebola epidemic in West Africa, he served in Sierra Leone. He led UH in Northeast Ohio through the COVID pandemic. He was a dedicated mentor, and he really championed others' efforts to advance global health. A notable example includes his work to establish the CWRU and UH Row Green Medical Education and Research Building in Kampala, Uganda, a cutting-edge research hub that will support further initiatives in research, training, and medical care. His lasting legacy includes countless physicians and scientists that he inspired and mentored to advance health both here and abroad. And I have just a few housekeeping notes before introducing today's speaker. The webinar is being recorded and will be available to view from the UH Research and Education Institute website. Please remember to mute your microphones throughout the presentation. If technical assistance is needed, please contact the Research and Education team, Nicole Bollinger or Abigail Zona, who are on the call. If you'd like to ask a question, you can type them in the chat. Questions can be seen by all attendees, and you have the options to submit anonymously if you prefer. For those who are invited to the meet and greet session after the presentation, please remain on the Zoom upon completion of the Q&A part. Today, we're delighted to have Dr. Devi Sridhar from the University of Edinburgh as our speaker. We'd like to highlight that she's our series' first international speaker. The Health Services Research Center is committed to improving healthcare, not only locally, but also globally, and to developing international partnerships and collaborations. So we're very excited to have Dr. Sridhar with us today. She is a professor at the University of Edinburgh Medical School and holds a personal chair in global public health. She's the founding director of the Global Health Governance Program and holds a Wellcome Trust Investigator Award. Previously, she was associate professor in global health politics and a fellow at Wolfson College, Oxford, and a postdoctoral research fellow at All Souls College, Oxford. She was also a visiting associate professor at LMU Munich and guest lecturer at the Harvard School of Public Health and the Public Health Foundation of India. She holds a DPhil and MPhil from Oxford as a Rhodes Scholar and a BS from the University of Miami in the Honors Medical Program. Her work is concentrated in 3 areas: international health organizations, financing global public health, and developing better tools for priority setting. Her books include Preventable: How a Pandemic Changed the World and How to Stop the Next One, Governing Global Health: Who Runs the World and Why, and The Battle Against Hunger: Choice, Circumstance, and the World Bank. She's also published in many of the most widely read scientific journals. She served on the board of Save the Children UK, on the World Economic Forum Council on the health industry, and co-chaired the Harvard London School of Hygiene and Tropical Medicine independent panel on the global response to Ebola. Today, she'll speak to us about preventing the next pandemic. Dr. Sridhar, you're most welcome.
Perfect. Thank you so much for that lovely introduction. And for everyone who's joining the seminar online, it does feel strange to be talking about pandemics just as we come out of COVID. It's not a topic people generally want to talk about or be around, given it went from being quite an academic or far away topic to one that was a bit too close to home. So thanks for joining on this. And as you can tell from my accent, I might be the first international speaker, but originally from Florida and have been abroad for about 20 years. So yes, I'm going to speak for about 30 minutes. I'll start sharing my slides and kind of give an overview of where, at least I think, we're at with pandemic preparedness and response in a global perspective. And then we'll have time for Q&A. So I think there's a function where you can put your questions in there, and I'll have a look at those and try to get through as many as we can in the time that we have. So yeah, with that, I'll get going. I'm going to start sharing my screen. If for some reason it doesn't work and I'm going through slides, whoever can unmute, and Catherine or someone else, and let me know so I don't keep going on if I'm the only one who can see it. So I'm going to share my screen and it should start. There we go. Yeah, so we might think that this is hopefully another 100 years until we face something like we face with COVID-19. Many said that the previous most like event was the one in 1918, the influenza pandemic. But actually, if you're working in global health, there's constantly signals of worrying events happening. So for example, bird flu in US cattle has been a major cause of concern because for the first time, we've seen mammal to mammal transmission in cattle. And that had been kind of suspected before, but actually now confirmed and spreading in a new population. And unlike seeing avian flu in chickens or in birds where you can cull or have lockdowns, cattle is big business. I think each cow is around $2,500. There's a lot of money there in terms of the dairy as well as the agricultural industry. And so that has an added economic dimension, but that's been something I know very worrying to people over why this new mutation has occurred and what does it possibly mean in the future as well. MERS continues to simmer in the Middle East. It's another coronavirus, a much more deadly one. And there is worries about it continuing to flare up, though it hasn't yet spread in any large way. But it's still there and quite worrying. And most recently, and what I guess people are talking a lot about in health now is monkeypox and why this new strain has been spreading so quickly, especially among children, which we hadn't seen in the previous years, and WHO declaring an emergency and trying to understand why has this mutation happened? Why is it transmitting among kids? Why are the fatalities so high? And while it started in the DRC, it has now spread to many other countries, and trying to get vaccines out there. And I just raise these because I think because COVID was so exceptional, people tend to think that outbreaks are rare events, but they are not. I mean, they are happening all the time. They were happening for a while, and we'll go through that a little bit. And they seem to be happening in increased frequency in terms of the numbers of events that we're having across the world. This largely has to do with our interaction with animals. Most of the diseases we get are from things that we come across, whether they're bats, rats, monkeys, cows, chickens, and then these are usually intermediary hosts or primary hosts, and they jump into a human. And if that can sustain human-to-human transmission, we're in a lot of trouble because it's hard to measure, as we've learned, kind of the interface of humans, where if it's animal to human, limiting that spread, it's pretty impossible, I think, to stop spread within the animal kingdom. There is an estimated, I think, 1.8 million viruses circulating there. Bats are just home to hundreds of different coronaviruses if you just go and kind of look out in hotspots in East Asia. But so it's about limiting those interfaces. You add on top of that worldwide traffic and travel now through airplanes, and actually something that's spreading in one part of the world will spread pretty rapidly across the world. And how infectious disease modelers try to look at the spread is actually air hubs and transportation networks and passenger numbers, and trying to estimate based on passenger numbers how many people are likely to be infectious from certain areas, where they might travel, how it might spread. And even we saw, like during COVID, the shutdown, for example, of flights from China. But if you look at where a lot of seeding was happening in Europe, for example, it was from an Austrian ski resort, and the Austrian ski resort was responsible for the majority of imported infections across Europe. It wasn't actually directly from China, which shows the limitations as well of using simple air traffic models to try to model spread, because actually humans move in more complex ways than just in one direction. And so WHO, I'll come to talk more about the World Health Organization, is monitoring these. And part of the difficulty, as I said, is in how many there are. This is the last kind of estimate they gave, which is that, they're monitoring thousands of events over the course of years. They have to choose based on that, what are the signals that they want to follow up on? Are they actually going to investigate them, send a team to the ground? And usually these signals are clinicians who are sitting in clinics and seeing something unusual and then feeding it into the system. And then WHO has to assess, is this something novel, something known? How do we actually manage it? And most of these events are managed locally, nationally, and sometimes regionally. It's very rare for things to actually go completely global out of the kind of thousands of events that are happening. And this explains partially why on the 5th of January, when the World Health Organization came out and said, actually, there's something strange going on in Wuhan. We don't fully understand it. We don't know what's causing it. We think it's linked to this wet market. I know that I've sometimes gotten questions of why WHO didn't make a bigger deal at this point. 5th of January is quite early on compared to when many countries started to respond, which wasn't until, March, April. And I guess the thing is, because so many things are happening and you can't scream every single time, it's like crying wolf. And so having to quickly look at the signals you can get, especially in a context where you maybe not are getting the full information from the government, and having to then assess, actually, is this something we need to escalate, or is this just the usual? And that's some of the difficulty of why some people said that why wasn't anyone moving 5th of January? I said it wasn't until even mid-January that human-to-human transmission was formally confirmed. And, it wasn't until, I guess, a week or two after this that they even understood that it was a novel coronavirus, and that was known globally. So I'm now going to turn to key steps and pandemic preparedness and response. How do we start to think about this area in a structured way, largely to guide policy. This is quite an applied area of working with governments and international agencies to try to prepare. Looking at what is the existing system of pandemic preparedness and response, and what does it need to deliver. And third, some reflections on major gaps in our system currently, and some worries as we go forward into what might happen in the future. So this is putting the source in. I know you'll have the slides later if you want to read more about it, but it's from an article I had done 2 years ago. So the first is monitoring zoonosis. We need to know where are those animal-human interfaces and which pathogens are most likely to make the jump, the anticipation, and trying to limit these, but also anticipate what are the priority diseases. The World Health Organization has played an important role. They go out to hundreds of scientists and ask them to assess the risk of various diseases. Part of the assessment is based on the existing tools we have, possible mutations, fatality rate, hospitalization rate, and they've come up with a list of what they see as priority diseases where you would be focusing on. And so the first thing is just getting a sense of that actually a lot of this is going to start with an animal-human interface, and that's where you need to be looking anywhere in the world, beyond whatever country you're in. The second thing is sequencing globally. It was vital early on to know what we were actually facing, that it wasn't a novel influenza, that it wasn't an original SARS or MERS, that this was a novel coronavirus. And here as well, this has been very important with monkeypox to understand that actually it was now a different strain spreading. And also with avian flu to understand that mammal to mammal transmission was happening, because they could actually fingerprint it and go back and have a look. And so the challenge here is that some countries like the United States, Britain, Denmark are very advanced in their sequencing, and the places where you might see these emerge and go undetected. Ebola seemed to be spreading for quite a while in Guinea without being diagnosed as Ebola. That actually we need to be building this globally in all parts of the world, so that actually as soon as something does occur, we know what it is. It sounds obvious, but it does require a certain amount of lab ability, human resourcing, and building those kind of facilities to quickly get the data and the sharing out to the rest of the world. The third is, once you have the sequencing and you want to develop products, and these could be vaccines, they could be antivirals, they could be whatever it is that you think if you need a medical measure to try to counter this. And we as humans are pretty good at developing some kind of medical countermeasure for most diseases that have emerged of one kind or the other. But we need to strengthen the manufacturing, because it's not only enough to develop it, has to have enough for the whole world. The world is currently dependent on a few manufacturers. One of those is the Serum Institute in India. And it creates a huge vulnerability in the system, because when not enough doses are available, then those doses and those manufacturers can be easily bought up by a few countries, leaving big gaps in the world. So the real question is here, how do we mass produce high quality medical products? And that means having to think about intellectual property ahead of time, so we know what is possible to release IP in certain emergency situations. What is the pricing going to be for low income settings? Building the factories, training the people, and getting things in place ahead of time, because as we saw, and I'll come to in a minute with even the COVID vaccines, it was quick to be developed, but the rollout was much slower across the world because of this block in manufacturing and getting out for the rest of the world. And this is also, we can talk about in the Q&A, also a kind of there's a real economic model behind it, because you don't want to build factories that go sit empty. So it's about actually how do you build factories that have another purpose for much of the year, but can quickly switch to pandemic production if needed for an emergency product. And so that is one of the considerations here, that it's not simply health, it's also actually thinking about the business models behind these. The fourth is, again, preparing vaccines for rapid production, because that might be your best bet currently against monkeypox, avian flu. There is the hope that a vaccine will be one of the key routes if it does spread more widely, and already being used, actually, avian flu vaccines are already being used for high-risk people on farms, and monkeypox vaccines being sent out to those African countries which need it. But here it's about preparing those plug-and-play platforms, as they're called, that could be quickly modified once you have the sequencing. So plug and play is almost like I tried to explain, like as a video game, that basically you have your console and you can just insert the sequencing and then you can manufacture on a large scale. So it's actually getting those platforms ready to go. And that's what really helped with the COVID vaccine being developed so quickly, but it's continuing to develop those platforms and adapt them going into the future. And finally, if it does start to spread, how do you stop the spread? And I actually think out of those four prior to COVID, this probably got the least amount of thought, which is there a way to delay spread until medical interventions can be rolled out and health systems are ready to cope with the volume of patients who might be coming through? But is there a way to do it by avoiding lockdown and school closures, which we know carry massive harms? And so I think here, as much thinking as we can have in terms of what are ways or other tools that we have in public health beyond very crude ones of saying to people, you can't see each other, or children, you can't see each other. And so I kind of hope in these 5 areas we'll spend more time in the preparatory phase. And then later on, there is an agreed way of moving forward instead of kind of a knee-jerk response over what do we do now? So this is kind of a mapping we did over how to start to think about it and who's responsible, because some of these are global functions. So pre-pandemic, we need to invest in disease surveillance programs. That is a global function. When the start of the outbreak happens, we need to initiate a rapid and coordinated global response. That's again for everyone. And the 100 days after outbreak, if we think, 100 days when we should be having things in place and ready to go, thinking about equity and access to products. Then what is national? So that, the national countries need to be thinking about in their planning in terms of their, pandemic response infrastructure, their public health workforce, their health systems, and thinking through how that would go forward. And then locally, how actually do you engage like local community leaders and people there and build that trust so that when a global response is happening, it's not seen as an imposed top-down response. We saw a lot of pushback against that, a lot of misinformation shared, and hesitancy because people didn't trust kind of the global project. And so trying to kind of think it through at each level, how do you engage? So that's just a way to kind of start thinking through at the policies that should be in place currently, as we kind of think through what can we do better and how do we improve it at each level. I'm going to turn now to the global governance of outbreaks, because I think we know a lot about how national governments can try or not to respond to the tools they have. But actually, outbreaks are one of the unique things in health where you do need a global response because of that issue that you can have something emerge in China or Kenya or the United States or Canada, and it becomes global. And so actually all countries are in this together and tied. We're one humanity, bugs spread. They don't have much respect for national boundaries or passports. And so the 4 things that we would need of a global system beyond national system is first to strengthen core capacities. This could be in workforce, labs, genetic sequencing, but basically what does every country need to have to be able to be part of that chain of response so that we don't have a blind spot, let's say, in the world map in terms of what's happening, and that's in everybody's interest. The second is to mobilize external assistance. So if the region is struggling, how do we actually get other countries to come in and help and support whatever they might need, whether it's vaccines or it's money or it's personnel or it's operational response. So actually some kind of coordinated mechanism to say, okay, this area of the world needs help. How do we all go in? An example of this right now is in the Gaza Strip, where polio has paralyzed a 10-month-old. First time polio has been seen after 25 years because of a pause in vaccination campaigns due to the war. And so actually WHO has been a key agency who's mobilized quite a lot of doses. I think they are planning to vaccinate 640,000 children over the next couple of days and this week, because they want to go in, and that's a function of WHO to go in and say, we're going to run this emergency campaign to try to stop the spread of polio before it spreads further. The third is to rapidly produce and share knowledge, especially in an emergency situation. So one of the most vital things WHO has done in different outbreaks is actually tell other countries what is happening, how is it spreading, how are, how dangerous is it, what's the hospitalization rate, what's the kind of medical equipment you need, and share that. And so it's not replicated in every single country, that there's one source of information, of technical guidance. And then, of course, providing stewardship over the system to try to kind of organize a coherent response of, okay, this is what we think should happen. But I think these are kind of the four, you could say, functions of a global system of response. As I've spoken about a lot, the key agency here is the World Health Organization. It was formed post-World War II to be the international director and coordinator of health work. And while there are a range of agencies now, from the Global Fund to Gavi to the World Bank to various donors who are active in at least outbreak response, WHO holds, I would say, the legal and moral authority to work on this area. And I mean legal authority because they are the agency that rings the alarm bell to say that there is a public health emergency of international concern, which is the top designation you can give to an outbreak to say this is a big deal. It is binary, meaning it's not graded 1 to 6 like a hurricane. It gets rated 1 to 5. It is just yes or no. That's been criticized, but it's the way it goes. And so they will say, take alert, like recently with monkeypox, this is an emergency, pay attention, and then they'll remove the emergency when they feel it's no longer needed. And so WHO's history actually is the history of outbreaks. If you go back to 1851 is when you first see the International Sanitary Conventions, which was when countries got together and said, we actually need an agreed way of managing cholera, plague, and yellow fever. Countries had started trading, and across those trade routes, these diseases started spreading. And based on the spread of these diseases, countries realized that if they wanted to have those routes and that travel, they needed to do it in a coordinated way. Out of that, you got the international sanitary regulations. Then WHO kind of became the holder of these. The international regulations, until 1981, only focused on those 3 diseases. And the basic premise being that if you identified these diseases within your boundaries, you had to notify other partner countries about it. So it was sharing of information and management through quarantine and other public health measures. Finally, they looked at revising it based on SARS in 2003, and in 2005, the international health regulations were adopted, which David Fidler has called one of the most radical and far-reaching changes to international law and public health since the beginning, because it basically says that if something happens unusual, and there's certain criteria that countries have to follow as members of WHO, you must notify WHO within 48 hours and activate a system. You must share that information. You cannot hide it. It's part of being part of the international system, and because there's that collective vulnerability. So how the system looks, if we say, like, imagine something happens out in a part of the world. First, national surveillance identifies an event of concern, and they get 48 hours to do an assessment of the risk of public health. Is this something we know? How is it spreading? Could it spread to other countries? Based on the assessment, they report to WHO, and they should do this within 24 hours. So it's a pretty rapid system for WHO to get this information. The WHO Director General, it's now Dr. Tedros, or whoever it might be, convene an emergency committee to assess if they think this is something really serious. So if they think this could be a global event or something where we need that's unusual, there's specific criteria they look at. And they also consult with the affected state, because there are consequences for states which report, and usually they're negative to tourism, to trade, to economics. So countries generally don't want to say something is happening, but this system tries to get them to buy in by saying, if you don't do it, it could be you next who's affected by someone else not reporting. The emergency committee meets. This is a group of scientists from different parts of the world. They advise the Director General, who then issues what, if it is or it isn't a public health emergency of international concern, and if it is, what the recommendations would be. This might be about support to the country, travel measures, recommendations for other countries to prepare, whether they need whatever might be needed in that area, whatever information needs to be shared, and then that is ongoing. At some point, the Director General can withdraw the emergency and stand down and say it's no longer a public health emergency. But during that period, this is how you would know something is a big deal. And that alarm bell was rang by WHO in the end of January. So I know there was a lot of discussion over, is COVID, when did COVID become a pandemic? Is something a pandemic? But pandemic is actually a more I would say, constructed term or social term. It's like, is this a problem globally? Whereas actually the public health emergency of international concern is the legal way that WHO can activate the system and say this is a big deal to member states. So I'm going to come now for the final, I guess we have about 10 more minutes, to some challenges in the chain of preparedness and response in each of these areas, and I'll go through them. So if we look first at, where could zoonosis happen? The two main things are what we call spillover events. That's when something that's, natural in the animal kingdom, comes into contact with human and spills over into humans, or it could come from a lab leak. And so how do we actually regulate labs better and implement biosafety measures? Sequencing and path identification. The challenge here is, how do we figure out what it is and where in a faster way? Because the faster we know that, the faster we can get a response. And the next is the strengthening the platforms in mass manufacturing. Can we create these? Can we get the products to everywhere we need? So these, I would say, are like the policy dimensions of actually how you activate it. Stop the spread. How do you best, can you contain a virus without major restrictions and lockdown type measures? Can you use testing systems or other things like that? And finally, protecting the health workforce. What stockpiling or prep needs to happen to protect the first line responders? And I think that's something that often gets forgotten, that actually the people dealing with this are clinicians. It's usually doctors, nurses, those working in clinical settings who are exposed to the virus first and actually having to respond. And so thinking through the PPE needs or the preparatory needs or the guidance that you can give to the health workforce, because usually when, and it's not just true for COVID, for others as well, that when an outbreak happens, the loss of life starts in the health workforce, which is usually your most valuable asset, because those are the people who can actually contain it and manage it and medically respond to it. So I start with the first one to show the challenge of it and look at COVID and discussions. I'm not going to go into where did COVID come from. I think there's lots of theories. I don't think there's anything established yet. I think there is convincing research over a natural origin from a wet market. There is also some doubts about could it have come from a lab. In my book, I go through the evidence for both and kind of do an assessment, but I don't think you can conclusively say with 100% certainty where exactly it came from. Like you could say avian flu is now spreading in cows, or you could say that MERS is from camels. I think we don't yet have that intermediary host absolutely confirmed in consensus in the scientific community. And I think my takeaway from this going forward, if we say, okay, how do we learn, is, because I don't think we'll ever know that answer, we're too far out, is does it really matter for what we do to prepare, which is what markets are a bad idea. We should not be interacting with animals and humans in that kind of space. And labs need to be regulated in a better way, in a stricter way, so we don't have leaks. I think that is the takeaway message there from that, and how do we implement it rather than looking at where to put the blame for that incident and where it might have happened. The other challenge we have in this is what we call predictions versus signals and constant mutations. So predictions are, so imagine, you get asked as a scientist, what do you think is the next thing that's going to be a pandemic? Or what do you think we should be thinking about? And that's what governments want to know, or WHO has that list. You can kind of try to predict. You can say, okay, I think it might be this or that. But if I'm honest, we've been notoriously bad at actually predicting what will happen next. Part of it has to do with the constant mutations that occur, and that actually viruses are constantly changing. And so it becomes really difficult to say this version won't spread mammal to mammal when a new version pops up. I think the other thing is looking at signals. So often when I'm asked this, I talk about signals and I say, well, there are worrying signals in avian flu because it's not just from the States, it's other part of the world that we're seeing this. So there's enough signals to establish a pattern, which means that we can predict this is likely to form. And so you're using a lot of likely, maybe, could, but obviously like with SARS-CoV-2, I don't think anyone could predict we'd have a new coronavirus come out and cause worldwide damage. I don't think anyone could see that the new strain of monkeypox would be spreading among children and cause such a high fatality rate in under 5s. And that's partly the difficulty of actually communicating science to the public and people who don't work in it, is talking about how things change. And with change, you have to assess what has happened and then actually communicate it. And we saw that with the immersion of variants, the immersion of different versions. So you say one thing one day, and if you had said, I think 2 years ago, oh no, avian flu, we've not seen it spread mammal to mammal, it's usually bird to mammal, that wouldn't be true today. And that's some of the difficulty, that we can predict all we want, but actually there's a lot of uncertainty in what could happen. The next thing is talking about vaccine sequencing and production. And the real focus here is on this, what's called the 100 days mission, which is within 100 days, can we have an available, safe, effective, affordable, diagnostic, therapeutic vaccine, some kind of medical product to respond so that we're on top of it. We did it faster than ever before with COVID. If you look at how quickly a vaccine was identified, it's remarkable considering how long it's taken for other diseases and for other challenges that we've had. That was around, as you can see, about a year. So now the challenge is, can we get it even faster? I think the problem here that I've seen is in clinical trials, and how do you speed them up while keeping trust in the process? Because those trials, even if they're expedited, phase 1, 2, 3, 4, as they were during the pandemic, they do actually take their time, and also to get the trust of the population that it's been tested robustly in a wide enough demographic, and that any safety concerns have been addressed. But then there's the issue of vaccine inequality. This was vaccine pre-orders to December 1st in the summer before we had the vaccine available. You might wonder why Canada bought up 8 times the number of vaccines in its own population. And partially it has to do with them not knowing which one would get through all the various stages of trials. And so what you saw was the United States and Britain and the countries that had major purchasing power signing agreements with manufacturers saying, once you get that agreement, whether it's from the FDA or here from the various regulatory bodies, we have the MHRC here, which is the UK one, then you will buy it. But the result, as you can see, is that a few countries bought up most of the vaccine doses and it left very little for the rest of the world. I think it was around 80% of the doses were bought up by the US, North America and the EU. So if you looked out when vaccines started to become available 3 to 5 months later, you could see that there are parts of the world that had incredibly good coverage. Look at Western Europe, look at Canada. And then you had parts of the world which were completely in red because sub-Saharan Africa, notably, because they just didn't have the doses. The United States is an interesting one, but I think there it had a lot to do with hesitancy and the political dimensions that the vaccine seemed to take on. So people were maybe a bit more hesitant. It didn't have to do, actually, I think, with availability. So the population vaccinated, if you look compared to most diseases, was super quick. Like, we did this faster. But in low-income countries, you don't see the same pattern. And that's kind of what we mean by vaccine inequality, which is, it's great if you're in the United States, but what does it mean if you're actually a healthcare worker who's having their next wave in Kenya and you are completely unprotected? So the next issue is, okay, imagine 100 days, you managed to have something. What do we do for those 100 days? You can't just lock people in their homes and say you can't go anywhere, and you'd have major riots if you try to do that. And so here, this is an article I did with Rebecca Katz at Georgetown. We tried to think through a decision tree for public health responses, factors that policymakers should consider, and how they design the kind of tools they might have. So we did this because we felt with COVID, there was a lot of talk of, is it flu? People are asking, is it flu? And I felt it was really unhelpful because, one, people were talking about seasonal flu, not pandemic flu. But also, it didn't really matter if it was flu or COVID. What mattered was, how was it transmitting? How many people is it killing? How is it affecting hospitals? And how do we deal with it? So this is one where we're saying, okay, let's forget what the causative agent is. We, of course, need to identify it and locate the origins. And that's the parallel activities on the bottom. But actually, what policymakers want to know, if you're head of Scotland or you're governor in the States, is, how is it transmitted? How infectious is it? What's the case fatality rate? What's the risk? Is it killing kids? Is it killing pregnant women? What's the demographic hit? What are our global coordination mechanisms? What can we get from other countries? What information? But really importantly, what are your policy tools? Like, do you have financial levers to provide money to people to stay home, like furloughs, what they did in Britain? What are your mandates for behavioral change, like introducing or banning masks as this is happening? Can you control human movement by saying to people, you can't move across state boundaries, or you can't leave the states? But same with animals. Can you manage cows moving and herds moving between states, or is that beyond what the state can do? And what are your medical measures? And so we wanted to put this out there to help have a way that when you sit down and kind of think through this logically, you can think through the major factors in designing your response. Part of the challenge of this, and this is, I guess, several of you might have as well, in advising governments, and I was a close advisor to both the Scottish and UK governments, is we didn't know a lot of the stuff at the start. So at the start, I kind of made this table for myself. So this table actually is from January 2020, and I put in what we know about some of the key topics being asked about and what we don't know. So at the start, I can tell you in January 2020, what we know, there was pretty much nothing in it. So all those questions you were getting, which was, oh, how much of our population is immune, or how many people have had it? We didn't know. We didn't know about long haulers or long COVID, as you might call it, or the pediatric multi-system inflammatory disorder. That was all novel. We didn't understand the pattern in children and why at the start, at least in schools here, it wasn't spreading, but then children also were less affected by it. But then as time went on, children started to spread it more and more. And so I just raise that because it's all well kind of presenting a slide like this and making it seem like you have all the information. But I think it was what was probably most difficult in advising a government was how little you could answer concretely the questions you were being asked. One of the big ones is, will there be a vaccine? And I remember sitting in a meeting with a colleague and he kept saying there wouldn't be a vaccine in time to affect the trajectory of the epidemic. So we could not work on the premise of a vaccine. And I was saying, well, actually, CEPI was investing in these new platforms and it looked like possibly we'd have one. You can imagine a minister sitting listening to both of us would wonder, I don't know which one is right. They both sound pretty credible in what they're saying. He couldn't say there definitely wouldn't be, and I couldn't say there definitely would be. We were both kind of looking at the signals and saying, this is what we think. And I think the thing that we could predict, and I remember this was a really big thing, was about healthcare collapse and what would happen to healthcare in the absence of any kind of mitigation strategy to slow the spread or stop the spread or whatever you might want to do, that if you just let a wave go through, you were looking at crashing your healthcare system, which meant deaths, not just to COVID, but to everything. It was just literally, you would have hospitals shut down. And that did happen in several parts of the world. And I know New York City and the state struggled quite heavily. India faced this during the Delta wave and other places as well. And so when you come to this, even though we didn't have much information, countries had really difficult choices to make from a policy perspective on how to respond in the, whatever you might call it, 365 days, 100 days, in the absence of knowing even if they would have a vaccine at the end of that period. New Zealand was very clear. They just wanted to lock down, not let anyone on or off the island, and try to eliminate and wait for some kind of medical hope. Germany and South Korea knew they weren't an island. They went for strong control measures, which meant we're just going to kind of, for me, it was like an airplane just circling because it can't land, which is like, we're going to keep flying. We're going to keep trying to handle this, keep our waves low, but we don't know how we're going to manage it. And then you had some calling the Sweden model, which is like, there's going to be no vaccine that's going to affect this. We just have to run it through the population, try to kind of keep life going. And you can see at the start, all three were kind of valid points and had to depend on where you were in your pandemic, your health services capacity, your geography. Islands generally did better because they were able to limit importation more and control how much virus was coming in and then manage it internally. But then vaccines happened, and all of a sudden, I'm just showing kind of how different strategies panned out with South Korea with the control, and the US and the UK, which I guess was more mixed in the US depending on the state, but in the UK was more actually just taking the waves. And then you had post-vaccine strategies. So the vaccine came along and New Zealand pivoted and immediately said, we have to vaccinate. So they changed completely their model of approach. I think it was Jacinda Ardern, the prime minister at the time, came out and said, guess what? You're all going to get it. We have enough Pfizer vaccines. Get vaccinated, especially if you're over 70, over 80, because we're opening up and you're going to get it. And they managed to vaccinate, a huge bulk of their population by the time Omicron came along, which contrasted with Hong Kong and China. And the consequence was that actually, even if you had done well in the first 2 years until January 22, managing it, as soon as if you didn't vaccinate your population, your death rate, and this is with Omicron, which many people said was mild, and like, it's not mild if you're not vaccinated and you're elderly as well. And then if you look at the death rates, you can see just there, like the death rate changed in New Zealand from, 0.1%, the case fatality rate compared to Hong Kong. And so when I am challenged by people about vaccines saying they don't work or they have harms, I was just like, how do you explain these two graphs in populations, which you'd say are, if anything, you'd say the New Zealand population is slightly unhealthier than Hong Kong, similar demographic, similar age group. And so I think that just shows like the difficulty when you're advising with how having to pivot and knowing the tools and what do you do, not just in the first 100 days, but then getting those products out and getting people to take them. I'm going to talk quickly about the health workforce because this is a really important issue, not just, I don't want to talk about the COVID deaths, but this happened in the West Africa Ebola pandemic. Sorry, wouldn't say pandemic, regional outbreak, the effect of healthcare worker deaths from Ebola on mortality. And, Sierra Leone lost 7% of their doctors, nurses, and midwives in that outbreak, which means it has a knock-on effect on maternal mortality, infant mortality, under 5 mortality. So it comes back to actually, how do you protect your health workforce? The most, startling example being that the person who was on Time Person of the Year representing healthcare workers dies in childbirth just a year or so later. And finally, I'm starting to wrap up, what's real? In this world of social media and sharing of news, there was a new paper in Nature that actually says, if you show people fake and real news stories and they spend time on the internet trying to figure out what's fake and what's real, they're actually more prone to believing the fake news. And so actually so if you tell your relative who's into that, believes something about vaccines and microchipping, go look it up, they'll probably end up believing it more if they spend time on the internet and doing that research. So how do we balance that we use the internet and the wide web to find information with the fact that actually it has a lot of misleading information that can cause spirals into kind of webs of conspiracy over what is public health and the impact of these actions. So I'm going to stop there. I know I'm over time. Happy to take any questions. And a lot of this is drawn from the 2 books that I've done looking at the pandemic, but also before that, our systems of response. So I'll stop sharing there so we can have a look at the questions. Thank you. So should I head directly to questions?
We do have
Yes.
one comment in the chat. So I don't know if you want to look at that one. I'm not sure if there's a question at the end of it.
Yeah. So I can't see any Q&A in the box, but here I can see that there's a question regarding the lab leak versus wet market hypothesis. I know that a piece of information that made people argue against the wet market is that patient 0 hadn't gone there. Given what we know about asymptomatic patients, though, what's the possibility that this patient was in contact with someone who had been to the wet market and wasn't visibly ill? I think that's very valid. And I think that's part of the difficulty with trying to even assess who is patient 0. Patient 0 is probably the person who presents themselves in a clinic as unwell. But if there are, as we've seen with COVID, it's like the tip of the iceberg, there are quite a few people who will be mildly ill or not ill enough to come in to a clinic. They could be out there and we wouldn't even know they're patient 0 unless they presented themselves. And then with genetic sequencing, you could work back to see actually who was the first infected, but you wouldn't be able to do that unless those people presented themselves and hard to find them. So I think that's fair enough. The next one, with regard to policy matters, the hierarchy that WHO holds legal authority seems to have evolved within the past couple of weeks, with the African CDC declaring a public health emergency of continental security. What is your perspective on this? I think that it has been great to see the African CDC become more bold and become stronger. It doesn't have the same legally binding authority that the international health regulations are supposed to have. So the WHO, because member states kind of signed on to the agency, they're supposed to follow what it says. They don't always do, but that's the way it's supposed to work. The African CDC is a technical agency, so it doesn't have that same legal authority, but I think it has a lot of credibility in the world and a lot of, I think that's a very strong statement when it comes out and says, pay attention to what's happening here. I also think one of the consequences of COVID was the African CDC, supported by the African Union, wanting to be more regionally independent. I think they felt very let down by the West. Their vaccines were supposed to be shared. There were supposed to be, financial agreements made, and that all kind of got negated, especially when high-income countries realized they needed boosters. So all of a sudden it became, okay, let's just vaccinate. We'll just do our population with 2 and you can have the rest. But when they realized boosters were needed, and quite frequently that sharing broke down. So I think one of the interesting things you've seen in, as you say, in the past couple of weeks, in the past year or 2, has been Africa as a region coming out much stronger to look after themselves because they feel other parts of the world aren't having their interests as a priority. And if you're interested on that, I had some senior scientists from there I interviewed in a documentary I did for the BBC called Vaccinating the World, and they talked a lot about their frustrations with how the vaccine was rolled out. Next, how do you propose to deal with social media and disinformation? I'll be honest, I don't know. I think this is something I really, really struggle with because I can also say, like, I have people in my life who believe a lot of this, and I find it very hard to engage with them. I've had people share information about me that's not been true and that's spread more widely. I think someone shared a Facebook post in the middle of COVID that got like over 5,000 likes that said I had never gone to university or something, and that I was a self-appointed professor, which is ironic given Twitter is the place to become a self-appointed professor. Anyone call themselves professor, and then people call them professor on Twitter. And so that I've really struggled with. So I have a lot of admiration for people who are trying to deal with that, who continually engage and try to kind of debate it. But I think there's a real sense of exhaustion in the health community after COVID, because so many people were so public facing to explain what was happening, to fighting that on a daily basis, because there's a lot of personal attacks that come with it. I mean, I think Tony Fauci in the States is the classic example of how much he took trying to do his job in a credible way and being an incredibly distinguished scientist and still having that challenged. But yeah, if anyone wants to do research in this area or explore it, please do. The final thing I'll say on it is, having been on Twitter and Instagram and these kind of platforms and kind of observed it, I do notice that if you spread misinformation, you become much more popular. Like, your follower count goes up, your likes go up, your RTs go up. It is an instant way to become popular and build a cult following. And so I have seen people who don't believe things and who I wouldn't think would be posting things do that, because they'll all of a sudden get a platform. So instead of getting 2,000 views of their YouTube channel, they get 2 million views. And that can be intoxicating for someone who does like attention and kind of thrives off that currency in social media, which is likes and followers and RTs, retweets and things like that. And so I often I'll say it, like, if I had written a book saying like COVID was a conspiracy, the great hoax, it probably would have sold much more, because that's what seems to sell. Whereas if you actually kind of try to give a balanced, measured perspective on trade-offs and difficult decisions and uncertainty and the scientific process, nobody really wants to read it, because it's probably not sensational and it's quite boring. Should I take one more? Are we out of time?
I think we should probably wrap up now. That was excellent. Thank you so much.
Perfect. Well, thank you all for attending. I guess that's the first part, finished. And I'm sorry if I couldn't answer the last 2 questions. Hopefully I can answer them another time.
Great.
Thanks. I'll just jump in to say that I think we'll just take a few more minutes for people to sign out. And I guess while we're waiting for this, I have a very, I would say, pragmatic question. As a center director, my questions are, of course, where can we focus our energies, and kind of, a center that's really dedicated to improving global public health. I'm just really curious, the key research gaps that we can address to prevent the next pandemic. Means a lot of this, what you mentioned, relates to what we do in terms of implementation science, policy-related work. So any key research gaps that you could suggest?
I think there's gaps along that whole chain. I would say the 5 steps. I think there's gaps in terms of understanding the risk and like where are the hotspots in the world to, spillover events happening. What are labs that we need to be looking at closer? So I think starting from zoonosis, same with sequencing and understanding that, and kind of the whole idea of developing medical products. It's great the WHO does it, but I think actually what strengthens this research is if multiple research groups do it and kind of triangulate across each other, rather than just one body doing it who maybe might miss things that other groups may not. But also like the health workforce challenge of actually just solidarity with your medical colleagues in other countries and the universities are sitting in their health clinics and building those collaborations. But it seems like I was reading the bios of all the panelists here, and many of them have had very close collaborations with institutes in various countries and like building those up. But Yeah, I think there are a lot of gaps, and like the big one they said, it may not seem like a research area, but the area of disinformation and misinformation. And if public health as an enterprise is based on, or even for clinicians, part of that trust is someone comes into your clinic and you say to them, this is what I think you have, and this is what I think we can do. If they don't believe you because they read something online and they're like, but I don't believe you because I saw this doctor on YouTube and he said this to me, that is a real challenge. So and that's an area I haven't seen enough work in, which is actually how do you deal at the front, like when you're in a clinical setting or in a public health setting with people who just believe other things. And I'm like, their beliefs, it's like religious beliefs. You can't really speak to them in any way about it in terms of like, they believe what they believe. And I know doctors here in Edinburgh have said it, like they had an ICU doctor, I had an ICU doctor who's a friend. He said they've had family members deny that the person they love has COVID and refuse treatment. And that is because of whatever they've read online. And so I think that's an area we don't traditionally think is of health, and it's quite new, but actually it profoundly impacts health, especially in something like a global emergency or an outbreak, when people are like, I've lost track of how many letters I've received asking me to mail them back SARS-CoV-2. They're like, show me the disease and I'll believe you. And I'm like, I don't know what they expect, but people want to see it. So yeah.
Thanks, Debbie. I'll now stay quiet over to all of my colleagues here. And